Good morning, good afternoon, good evening, students. Welcome to the second topic, which is dyspnea or shortness of breath. So the objectives of this talk again are: we should be able to list differential diagnosis for dyspnea across the systems. We should be able to evaluate a patient with dyspnea using 4 steps of epilogical approach. We should be able to appropriately order labs and imaging after clinical evaluation, and lastly, we should be able to recommend appropriate treatment and basic management plan based upon the diagnosis. So as you know, that dyspnea spans across multiple systems. So there can be respiratory and cardiovascular causes of dyspnea, which are the two main ones. And then there are hematological causes, endocrine or metabolic causes. There are psychogenic causes, toxic and drug causes, and environmental causes of dyspnea. And then lastly, there are neurological causes and then musculoskeletal causes of dyspnea as well. So dyspnea does span across the systems. How do we approach a patient, and how do we come to the right diagnosis? That is the whole point of this talk. So this is just a very high level review of all the material that you've already learned during systems courses. So there is very little new material, but we will go in more depth when we need to look at our approach. So how do we approach a patient who comes in with shortness of breath, and how do we know what category of diseases our patient belongs to? So we will identify some high yield questions, and also we will recognize some red flags and recognize life-threatening urgencies and emergencies. So let's get started. So the best way to broadly differentiate or categorize dyspnea causes would be based upon duration. So dyspnea can be acute dyspnea, which is less than 4 weeks duration, and chronic dyspnea more than 4 weeks duration. So this is just a very broad journal way to divide dyspnea. These are just ballpark numbers. It doesn't have to be exactly less than 4 weeks or more than 4 weeks. And you'll see that there is a fair amount of overlap. Most sources will use 4 weeks as a cutoff value, so that is why I'm using it here, but we'll expand on it a little bit more here. So you can see that cardiovascular causes, for example, coronary syndrome, which is your MI and your unstable angina, asthma exacerbation itself, then pneumonia, pneumothorax. So these are your respiratory and cardiovascular causes. Some more: pulmonary embolism, AFib, arrhythmias, and any kind of arrhythmias. And then there is aortic dissection, and then pneumonia and bronchitis. All these things can cause shortness of breath of acute duration. And then very important, you have congestive heart failure exacerbation. So not just heart failure, but exacerbation of it. Valvular dysfunction, aortic stenosis, and pulmonary edema will also cause shortness of breath. And pulmonary edema patients usually have another problem already going on, and in that setting now they develop pulmonary edema as a complication, and that's how they develop dyspnea. Then you have metabolic causes or endocrine causes, for example, DKA. So patients with diabetic ketoacidosis, usually they have chief complaint as altered mental status, or there may be some different chief complaint, not shortness of breath. And now because they are so acidotic that they develop dyspnea as well. And then you have anemia, so hematological causes. So patients drop their hemoglobin very low, and that's how they present with dyspnea. Then also patients who get exposed to some poison or toxin, or they are in high altitudes, they can have some dyspnea with accompanying symptoms. And lastly, you have some ARD, acute respiratory distress syndrome. Again, this is going to be a hospitalized patient who's already sick, and then you may have some pleural effusion or pericardial effusion. These again develop as a result of something already there, and we'll talk more about that. So patients don't just come in previously healthy and now they've developed this. So they usually have a past medical history of significant illness. Patients with sickle cell disease come in with acute chest syndrome. So they develop a pretty bad chest pain, and then now they also have dyspnea. And then lastly, you have very rare causes of dyspnea, luckily or unluckily, but they are Guillain-Barré syndrome patients and stroke patients. So see that these patients are going to come in or going to present in a setting where they already have some neurological dysfunction. So for example, their chief complaint would be paralysis or some weakness, and now because of respiratory muscle involvement, they develop extreme shortness of breath. So you are not going to see them as with dyspnea as a chief complaint necessarily. but because they cause dyspnea, that's why I have entered these diagnoses here too. Anyhow, so your chronic dyspnea patients, most commonly you have the obvious causes. So you have patients who are pregnant, so second or usually third trimester pregnancy patients have dyspnea. Obesity, so patients with hypoventilation syndrome, they can come in with shortness of breath, and usually it's because of deconditioning. And then you have kyphoscoliosis patients who have severe structural disorder, so they can't expand their lungs very well, and now they have dyspnea. And you can see here there is a group of problems or diseases that can cause chronic shortness of breath, and there's a lot of overlap. So they're very similar to acute causes, except that your patient with acute coronary syndrome has angina, so not unstable angina but chronic stable angina. They can have chronic dyspnea. Patients who just have COPD or asthma but they don't have any exacerbation, they just have chronic dyspnea. Then heart failure patients, again, they are fairly stable, so they don't have an acute decompensation, but they just have chronic dyspnea and they're stable with medications. And then again, your patients with some pleural effusions continue to stay there for a long time, so their dyspnea can progress for several weeks, so that's how it can become chronic. And then you have patients with anemia. If they've been hovering around borderline anemia, for example a hemoglobin of 7 or 8, they just stay dyspneic. And then again, another diagnosis, lung cancer and TB. Although these are usually relatively acute presentations, these patients don't wait for weeks and weeks until they develop symptoms, but their dyspnea can stay there for a long time. So and a part of that is because they don't develop dyspnea right at the onset of the illness. So for example, a TB patient will have infection for a long time and they haven't developed respiratory symptoms yet, or if they did, they just had cough and no dyspnea. Or lung cancer patients started to develop some weight loss and some maybe cough for a while, and then finally when more and more lung parenchyma was involved, they develop shortness of breath. So this can present as a chronic problem. Interstitial lung disease patients, again, your rheumatoid arthritis, your lupus patients, your interstitial lung disease patients, they can develop dyspnea of chronic duration. So again, because the shortness of breath is quite subtle and it's not very significant, sometimes these patients don't even seek any medical advice. And then your patients with valvular dysfunction, again, if the dysfunction is not really severe, they can have symptoms for a long time before they come in. And then lastly, we already talked about it. So whenever we have acute and chronic category, and we ask about duration, that's how we can lean to one category versus the other more easily. Therefore, duration is the most important question to ask whenever we're seeing a person with dyspnea. But even before we ask about duration, it is important to recognize red flags, because dyspnea is such an alarming symptom. People, you can see from multiple diseases in this category can cause death. So because it is such an alarming symptom, we must recognize red flags and we must identify if it is a life-threatening emergency right now or not, and what do we need to do about it. So what are some of the red flags situations in the context of dyspnea? Well, this patient, in addition to abnormal vital signs, for example low oxygen saturation, tachycardia and tachypnea, may have some stridor, and stridor will develop if there is upper respiratory problem or upper airway obstruction. So in the setting of upper airway obstruction, these patients usually have inspiratory stridor. So just remember stridor for upper airway. And then they can also be using accessory muscles of respiration. By the time they've started to develop this, the dyspnea has become really bad. And also you will notice that they are not able to complete a sentence because of shortness of breath. So whenever you see this right at the onset when you're seeing the patient, then it means trouble is there, so we need to intervene right away. Cyanosis is another red flag, but it usually doesn't develop in adult patients, so it's not very common. But if it is there, it's a really significant sign of acute distress. So usually we see cyanosis with in the case of poisoning or or some cardiovascular abnormalities. We see more of this in pediatric situations, and we'll talk about that in a second here. So whenever you see any of these symptoms or signs in the presence of dyspnea, then it means it's a red flag situation. So that is why, in addition to looking at vital signs, we should ask about these things or look for these things whenever we are evaluating a patient, and then ask about duration. So whenever these red flags are present, the correlated or corresponding diseases or pathologies, usually in the upper airway, especially when stridor is present, would be either anaphylaxis reaction causing angioedema, or there may be foreign body, or there may be a severe infection in the upper airway, for example red pill infections, and you all know about those. And whenever you see it, we must ABC this patient, and you all know what ABC is. So this is just a quick overview of the upper airway obstruction or problem causing red flags and acute distress and dyspnea. And we'll expand on that a little bit more here. So what is the approach to a patient? Well, first of all, just like I said, we look at the patient and see if the patient is stable or not. And if they are not stable, usually they are not able to talk. And if they can't talk, then it means we're definitely going to look at their vitals, and then we're going to look for stridor and accessory muscles use and drooling. If any of this is present, then we'll say, okay, these are red flags, let's intervene and keep these diagnoses in mind. So in addition to the upper airway, we will look to see if there is any history of trauma, which may show that the patient has flail chest, so their chest is moving in the paradoxical direction. Status asthmaticus patients can present with all of these except with drooling, so they can have a lot of these things present. So we'll definitely look for this diagnosis with history and proper evaluation. And in addition to upper airway obstruction, we will look for any exposure to toxins or drugs or any other severe condition. So remember, any severe condition, any condition that was present in the acute category, if it becomes extremely severe, it can cause or give rise to use of accessory muscles of respiration. For example, a hemoglobin of 3 or 4 will cause a patient to use accessory muscles of respiration. So in that case, this patient has become acutely ill, and now we have a red flag scenario. So before even we complete our evaluation with history and physical exam, we gotta intervene. So how do we intervene? We do ABC. And now on the other hand, if our patient is stable, which means they are able to use, they are able to talk without having to use accessory muscles of respiration, their vitals are not looking that bad, they may have mild hypoxia or mild tachycardia, but not really that bad, they don't have any stridor, no drooling, nothing like that, then we'll say, okay, let's complete our history. And the first question again should be duration, because this gives us a very good starting point. We know that, okay, we got to start asking questions about all those acute categories, and then we can the next good question is onset. Now okay, so angioedema, so now I'm going to talk about one disease at a time, and we'll just expand on the symptoms and signs and risk factors and approach to the patient whenever we are suspecting that disease. So for example, patients with angioedema, first this is a type 1 hypersensitivity reaction, so just keep that in mind after exposure to any allergen, and it's an IgE mediated reaction, so just keep that in mind for just etiology sake. What are the signs? Again, these are all the red flags, symptoms and signs. These patients are unstable. On top of that, they have additional symptoms. So whenever you see this, how do you know that this is angioedema or acute anaphylaxis? Well, these patients have generalized itching. Usually they can have urticaria, so a rash. Then they have swelling of lips and perioral itching, which is usually, or tingling, which is usually a very significant feature around the mouth and the lips. And then they also can have some swelling of the larynx. So whenever they have these symptoms and signs, then in the setting of some of these red flag situations, then we say, okay, this is angioedema. And when we go back in their history, they usually have either been exposed to a new food or drug or pollen or sting. and we immediately take action and we give them either steroids or actually both steroids and intramuscular epinephrine. So they get subcutaneous steroids or intramuscular epinephrine, and this is the treatment for angioedema. The next scenario is our status asthmaticus patients. So patients who have a history of asthma and now they come in with status asthmaticus. So usually, this doesn't mean that everybody who has asthma will come in like this, but this is only going to be those patients who have asthma but now it has gotten very bad. So they have something we call status asthmaticus. They are not able to talk, they are using their muscles, they have all the vitals abnormal, so they have significant amount of tachycardia and hypoxia and tachypnea as well. Additional symptoms and signs for status asthmaticus would be they can have silent chest. So actually classic status would be silent chest. So remember that not all patients will have wheezing. Not all that wheezes is asthma, and not all asthma wheezes. So they also can show pulsus paradoxus, and then when you examine them, now they may have some tympani on percussion, or it may be normal percussion too. So the point is, whenever they have any of these present, then you will assume that this is status asthmaticus, and this becomes just extra findings. On their history, you will see that they have been exposed to either some new allergen, or they ran out of their inhalers, or they just exercised pretty heavy all of a sudden. So usually these three are very classic things that are present, one or the other are present in the history, and then you say, okay, this is probably status asthmaticus, and this is how you intervene. These patients need steroids, otherwise it's really hard to bring them back, and then sometimes they always need nebulization, but sometimes they need intubation too. So what we do is we nebulize them regularly, or sometimes even continuously, and then we give them parenteral steroids, and they get better. The good news is they get better very quickly, but sometimes we have to intubate them, and there is criteria for intubation for status asthmaticus or COPD exacerbation, but that's beyond the scope of this talk. This is just a chest x-ray showing flail chest patient. So this patient broke a couple of ribs, and now their chest is moving in paradoxical direction. So that's just one slide. All right, so the next is another thing that another scenario that can come in. So your patient, of course, you ask them about duration, and if it is acute duration, the next question after you've asked about onset and duration of dyspnea, and you have determined the patient doesn't have too many red flags, then you ask about chest pain, because that is another good high yield question that will broadly categorize or differentiate between cardiovascular versus non-cardiovascular causes of dyspnea. And if they do have chest pain, of course, the first thing that comes to mind would be that, okay, it could be acute cardiac ischemia or MI or unstable angina. So these two are known as acute coronary syndromes. Anyhow, when you are thinking about it, what else would be present? Well, this chest pain is going to be very classic sometimes, or most of the time, but sometimes it's not. So the questions that we should ask about chest pain would be the onset, duration, alleviating factors, aggravating factors, severity and radiation, and timing. So all those O, P, Q, R, S, T questions must be asked. But anyhow, the patient will say that they're, along with the shortness of breath, they have substernal chest pain, it's radiating to the left arm, it's a pressure or a squeeze, and when all of this is present, then it probably is cardiac ischemia, especially in the presence of risk factors. So we must definitely suspect it. But also keep in mind, not everybody has dyspnea, so this is just an additional finding or additional symptom in cardiac ischemia. But that subset of patients who develop dyspnea because of cardiac ischemia will have accompanying chest pain, which will look like this. Now, there is a small group of patients who don't have classic chest pain. Instead, what they have is epigastric discomfort. And they also have some nausea associated with it. So this is very difficult in a sense, because it becomes tricky, because as soon as the patient says, I have pain in my upper abdomen and some nausea, naturally you're going to start thinking about things or pathologies inside the abdomen. But keep in mind, if you have this knowledge, you will evaluate the patient for cardiac ischemia too, that about 25% of the female patients who have cardiac ischemia don't have classic chest pain. And lastly, to complicate things even further, a percentage of patients who have diabetes actually don't have any pain at all. So they just have silent ischemia. They may not even have very significant shortness of breath. So what they do is they just have silent ischemia, and you just find out that they had an MI. That's too sad or bad, but anyhow, this can also happen. So therefore, it's very important to be cognizant of risk factors. So patients who have risk factors, even if they have subtle findings, we need to evaluate them for cardiac ischemia. What are the risk factors? So these are the big ones. So you have age, older age, history of smoking, diabetes is a huge risk factor, hypertension, hyperlipidemia, male gender, and family history of heart disease. So all of these are risk factors. In addition, lately we have found out that obesity is become a risk factor. Then also patients with renal failure, they also are at risk for cardiac ischemia. So you can see that a lot of chronic diseases are risk factors for acute cardiac ischemia, and because these are the patients who develop coronary artery atherosclerosis. What are some of the signs or physical exam findings? Well, surprisingly or not surprisingly, these patients have usually very normal cardiovascular exam, except for sometimes when they don't. But typically, your regular patient who has acute coronary ischemia will have a very normal cardiovascular exam. So we'll just evaluate them based upon our clinical judgment, our history, and our risk factors. And what are the labs and tests to order? Well, we'll order an EKG, of course, which will show some STT changes, and then troponins, which may be high if there is ischemia going on. Typically, if they have 2 of the 3 positive or 2 of the 3 negative, we can make a decision. But most of the time, whenever a patient has a classic chest pain, they have to be evaluated thoroughly. If they have a very atypical chest pain, and the EKG is also negative, and they have no risk factors, then you don't really have to draw troponin. So that's how we make this distinction. But you don't have to worry about this at this point, so we can just move on. This is an EKG showing different distribution of different walls when it comes to ischemia. So your lateral wall ischemia patients have STT changes and Q waves in the lead 1 and AVL. Your anterior wall have 2, 3, 4, and then your inferior wall patients have changes in 2, 3, and AVF. So this is how we can determine what wall of the myocardium is involved when we are seeing ischemia. Again, STT changes, especially ST elevation, will be the most important change. T wave inversion may be present, which all of these will mean acute ischemia or MI. But if you have developed Q wave, if the Q wave is present, then it means that the patient is already progressed to infarction. So the injury was or the onset of injury was more than 48 hours ago. That's how we can tell if it's a new infarction or an old infarction. This is a slide showing an EKG. So basically you can see there is ST elevation, pretty nice ST elevation in 2, 3, and then AVF. So this is an inferior wall MI, a nice ST elevation, and then reciprocal inverted waves in lead 1, 2, and that's pretty much it. So 2, 3, and AVF is involved. So this is an inferior wall infarction, and then there is some septal infarction present too. So next we'll talk more about another category where or another disease where patient has dyspnea. So you ask about duration and onset, and the next question you asked was chest pain, and it was present. Now this time chest pain is different, and we will think about pulmonary embolism when the chest pain is going to be like this. So patient says that, yeah, my chest pain started acutely, and also cardiac ischemia patients have very acute onset of chest pain, of course. So it's usually a few hours or maximum a couple of days. So it's not like weeks and weeks. And the PE patients also usually have a few days or a few hours chest pain. But this is going to be a relatively young patient usually, but it can also be older patients. So the pain is going to be pleuritic chest pain. So this is going to be worse with deep inspiration. So patient will take a deep breath in, and that's when the chest pain gets really worse. In addition, they may say that they have palpitations. This usually happens if they have developed tachycardia because of the PE, and that's how they feel palpitations. They can also have low-grade fever, although it's not always present, but if it is present, you may think that it is because of PE. However, if the fever is high grade, then definitely think about other causes of dyspnea and chest pain, or think that something else, another infection is going on with PE. So this, if present, should be low grade in PE. On top of that, these patients typically have leg pain or swelling of leg, and usually it's unilateral. So if you're suspecting PE because of typical pleuritic chest pain with shortness of breath of acute duration, we should ask about leg pain and swelling. Now, the patient may look at you with surprise, asking, why are you looking at my leg and I'm talking to you about my chest pain and shortness of breath? But the reason behind this would be because most blood clots that go to the lungs come from the leg. So